koutou, no mai, haere mai. Good evening, good afternoon, or good morning, wherever you are in the world. I'm Karen Thompson from the Alumni Relations team at the University of Auckland, and I'm delighted to welcome you to another great talk in our Raising the Bar Home Edition series. Tonight's talk has the intriguing title of On a Trip Back from the Fringe. And our speaker is Dr. Suresh Muthukumaraswamy. He is a neuropsychopharmacologist. Our MC tonight is Dr. Lisa Reynolds, Senior Lecturer in the Faculty of Medical and Health Sciences. Lisa will introduce Suresh in more detail in a minute, and later she'll talk to him about his research before asking the questions you, the audience, have for him. If you've missed any of our previous talks, you'll find recordings on our alumni website. Next week, our final talk covers the fascinating topic of gene editing, and registrations are open. Now it's time to sit back and relax and find out how psychedelic drugs can improve our mental health. Over to you, Lisa.
No mai, haere mai, tēnā koutou katoa. Ko Lisa Reynolds tōku ingoa, he kaimahi aho no te whare wānanga o Tamaki Makaurau. Hello and welcome everyone. My name is Lisa Reynolds and I work at the University of Auckland alongside Suresh. It's my very real pleasure to introduce Suresh for his talk tonight on raising the bar. Many of you will know his work. He was involved in some of the original studies that came out of Imperial College, looking at brain activity following psilocybin administration. And he's been paving the way in Aotearoa, looking at how various novel therapies alter brain activity and might offer benefit for various patient groups. But for those of you who haven't met Suresh, you might not realise what a great human being he is. He's super nice, very collaborative, and unbelievably humble for someone who has already achieved so much. So I'm sure you're going to pick up on that in this talk tonight. So you might have some questions on his talk as he goes through tonight. The Q&A function is going to be at the bottom of your on-screen Zoom panel is live. So please submit any questions that you have from Suresh's presentation, and we'll be monitoring these as we go along. You'll also be able to upvote any questions that have been asked, and these questions will move to the top of the Q&A screen. So towards the end of today's session, we'll be asking Suresh some of the questions that you've asked. So without further ado, I'm going to hand over to Suresh to talk to you about the really fascinating work that he's been doing. Over to you, Suresh.
Hello. I'm guessing, just bring this around. Try to see the Zoom chat. Right, hi everybody. Sorry, I'm now in this mode. I'll assume that I'll be stopped if you can't see me or hear me or see my slides. Thank you, Lisa, for the introduction, and thank you everyone for coming. It's a little bit strange talking to my computer and not being able to see any faces, but I'm sure I'll adapt. So I'll get on with my talk. So here we go. Okay, so the talk's about psychedelic drugs. And I guess, the good first question to start with is, what is a psychedelic drug? And I've listed some of the main types here. And for those who like pictures, put some nice pictures in of different psychedelic drugs. I won't tell you which one's which, but I'm sure you can guess at least some of them. So there's really no definition of what a psychedelic drug is. But one way we could think about them is in terms of their pharmacological categories. So we have like serotonergic drugs like LSD and psilocybin that mainly work through the 2A receptor, but then is MDMA a psychedelic? Some would say yes, some would say maybe not. Is ketamine a psychedelic? Some would say yes, some would say not. Cannabinoids, if you take a really large dose of THC, that can have quite a psychedelic effect. And then you have all these other random ones like salvia and scopolamine. And even experts disagree on what we should actually call a psychedelic drug. So there's really no answer to this question. But my working definition for the purposes of tonight's talk is that they're drugs that cause you to think kind of unusual thoughts. And this fits with Humphrey Osmond's original description of what a psychedelic was, that it's mind manifesting, and he defined this in the 1950s. And only later did we start to see these different pharmacological categories. I like to kind of think as pharmacology as sitting in these kind of broad sort of axes, and there's probably more axes in this, but this is a reasonable description. We have some drugs have kind of more stimulant actions, some have more depressive actions, some are kind of more antipsychotic, and some are more hallucinatory. And the psychedelics tend to sit in this kind of light blue zone, where you can see them kind of stacked up along here: psilocybin, LSD, mescaline, etc. But some of them are also a little bit more hallucinogenic, but also a bit more depressant, like a drug like ketamine. THC sits in there. So you can kind of see that drugs, at least drugs that operate in the central nervous system, kind of sit roughly in these kind of axes, but there's kind of a lot of blurring between the categories. So I'm going to be talking in this talk mostly about the serotonergic psychedelics and ketamine, and actually MDMA as well, now I think about it. So the serotonergic psychedelics have been used in cultures for thousands of years. So there's the psilocybin mushrooms from South America and Algeria. There's also native magic mushroom species in New Zealand. Mexico has the mescaline cacti. There's ayahuasca, which is this Brazilian tea that gets drunk. And there's a common thing that is that usage of psychedelics seems to be related to sort of spiritual or religious ceremonies. Although one of the things to point out is that some people would say, oh, psychedelics have been used. We see these like stone mushroom artifacts like I've got here on the right. So psychedelics have been used throughout human culture. But actually, we don't really know how extensive that use was across culture, right? And of the entirety of culture. Just because one person carved out the stone statue of a mushroom doesn't mean that whole society had been using it for thousands of years. That might have just been a couple of exceptional uses. So we don't really know how involved they were in human cultural development. And people that claim that they were, it's a nice story to tell. The modern interest in psychedelics kind of began in the 1940s, and in 1943, Hoffman, pictured here, much older than he was when he developed this, is probably when he was around 100 years old. He synthesized LSD, and he was the person that discovered its use by accident on a famous incident called Bicycle Day, where he rode his bike home after accidentally getting some on him in the laboratory. So bicycle display days here, and he immediately kind of discerned that this drug had these kind of remarkable properties. And following his discovery of this drug, he told some of his psychiatrist friends about it, and then they started investigating it, playing it with themselves, and then starting to do studies on it. And what they realized that these drugs had really powerful, they were a really powerful tool for manipulating human consciousness and making people think unusual thoughts. And psychiatrists of the day thought that maybe these could have some kind of therapeutic purposes. And so that research was, it was really, it was an extensive amount of research that we don't actually kind of really realize, because most of the people from that time, well, they're dead now. So you have to kind of go back into the history books to look at it. But what we do remember more is in the 1960s, these kind of drugs got adopted from the counterculture, from the hippies, the anti-war generation, and that led to the kind of it then being linked into the war on drugs, and then prohibition followed that. Now, and prohibition was based on essentially scaremongering about the potential harmful uses of these drugs. I won't try and play these videos, but suffice to say, there were many people in what one would consider to be pretty mainstream culture who were looking at these drugs as potential therapies. Robert Kennedy, the Attorney General of the United States, he was an advocate of psychedelic research. But for political reasons, it was deemed that they could throw psychedelics in with things like cannabis, make them illegal, and in the war on drugs. LSD. So skip that. So, and that's kind of where things, got to in around the 1970s for New Zealand. That was encapsulated in what we have the Misuse of Drugs Act. And so this is from the New Zealand Police website. And so you can see the modern classification of LSD. And you can see that LSD is placed in the very Class A, which has very high risk of harm. So this is how the Misuse of Drugs Act, drug classifications in New Zealand are based on risk of harm to the user and to people around them, but primarily to the user. And so LSD is classed as having very high harm, same with magic mushrooms and heroin, cocaine, and the different classes go down. And apparently it's based on risk. Now, the problem is with that, and this is, most of you will probably know this, is that there's really no scientific basis for this. So in this paper, my colleague David Nutt produced this, where what they did was they actually ranked the harm of drugs according to a number of metrics. And where blue is the harm to the user and red is the harm to others. Now, if the drug classifications were making sense, you would have the Class A drugs would be on the left-hand side, and the Class C or legal drugs would be on the right-hand side. But you can see that that's not the case. Actually, one of the most harmful drugs actually is alcohol. That's primarily because of the harm that it causes in our society. But the most physically harmful drugs are things like heroin, crack cocaine, methamphetamine, as we would think. But actually, way down here we have MDMA, ecstasy, LSD, and mushrooms. So when you kind of see that figure, and actually, this was actually a study that was done in the UK, that study, and actually the New Zealand Ministry of Health actually commissioned a study to do the same thing with the New Zealand data. And what you can see is that essentially the same pattern emerges. Unfortunately, they didn't include alcohol in their analysis. They stuck to illegal drugs, which I guess was politically convenient at the time. But you can see here that LSD, MDMA, these have very low harm. So what that tells you is that the classifications here are not based on any systematic evidence. It's just based on political convenience. So I'm going to be talking about the pharmacology of these drugs. So we're going to have one slide of pharmacology, I'm afraid. And so it's pretty simple though. The brain is composed of neurons, and we have a presynaptic neuron. The neurons themselves internally transmit information electrically. So an electrical signal comes from one neuron, and when it needs to communicate to the next neuron, what it does is it releases neurotransmitter, and then that activates the next neuron. And the next neuron then becomes excited and does its thing. So many of you will know what these neurotransmitters are. They're things like dopamine or serotonin or glutamate. And then the neurotransmitters bind to receptors to cause the action in the postsynapse. So we're going to be talking a little bit around the neurotransmitters and the receptors today. And that's about it in terms of the pharmacology that we're going to need to know. So how do the serotonergic psychedelics work? So the first thing to know about serotonin is you don't have really serotonin cells all through your body. What you have, so the serotonin cells, they all sit in the brainstem, in the bottom of your brain. And what they do is they send long axons up to all the different parts of your brain. And so you have cell bodies down here in the brainstem. They have big long axons that might project, 5, 8 centimeters up to the various parts of your cerebral cortex where you do all your thinking, your vision, all that sort of stuff, movement. And then they release serotonin onto the cells that are in this cortex. So they kind of neuromodulate brain activity. So what happens in the case of the serotonergic psychedelic? So serotonin would then bind to a serotonin receptor. There's a lot of serotonin receptor types. Only one that we're going to talk about today is 2A receptor. And LSD, psilocybin, and DMT, which is the active ingredient of ayahuasca, what they do is they actually bind to the serotonin 2A receptor. And it's thought that the psychedelic effects, these strange things that people feel when they take psychedelics, that's mostly caused by the single 2A receptor. And so you might ask me, well, how do we know that? What we can do in pharmacology studies is give people drugs that block the 2A receptor, and then what we can do is give them the LSD or the psilocybin, and that will actually block the psychedelic effects. So that way we can kind of work out that it's the 2A receptor that's really important. There are other things that we can kind of base it on. We know that the more potent that different drugs will bind to that receptor, and they'll be kind of more or less sticky with it. That's called its affinity. And the more potent drugs tend to be more sticky at the 2A receptor. But there's also something very curious that the psychedelics do actually at the 2A receptor. And they cause this thing called biased agonism. So what normally happens is that serotonin would bind to the 2A receptor. And so the serotonin floats and binds to the 2A receptor, and it just does its thing. And the serotonin 2A receptor binds, gets bound, and starts doing something inside the cell. And the cell just operates normally. So what actually happens when a psychedelic drug binds to the serotonin 2A receptor? It actually binds to it and actually causes the 2A receptor to actually change its shape. And when its shape gets changed, it activates signal pathways in here that are not normally activated. So even though it's just kind of binding to the normal receptor, it actually causes this shape change and actually causes a signal cascade within the cell that is not physiologically normally active. So that's probably what's going on with the psychedelic action of this drug, is that it's actually causing a non-physiological signaling pathway to get activated, which is kind of interesting and quite unusual in pharmacology. So another drug that I'm going to talk about some of the clinical evidence for is ketamine. Ketamine is a drug that I've been studying for nigh on 10 years now. And it was originally developed from PCP, which is angel dust. And PCP was being studied as an anesthetic, but it had a lot of unfortunate side effects. So what they tried to do was synthesize a kind of less potent version of it that could be used in anesthesia. And one of the reasons it's really good in anesthesia is that it doesn't lower heart rate and blood pressure, which it can be important in certain types of operations. And then, so they derived ketamine, which is called C1581 originally, and then Domino, who synthesized it, started the first human studies. And what they realized was at these low doses of ketamine, so at very high doses, it causes anesthesia, but at lower doses, about a quarter of what you need to create anesthesia, it had these kind of psychedelic effects. And so Domino's wife called it, they were trying to work out what do you call this type of anesthesia, and Domino's wife came up with the term dissociative anesthetic, because it kind of creates this feeling where people go out of their body and almost have these kind of out-of-body experiences. Unfortunately, the pharmacology of ketamine is pretty complicated, and actually this is true of most of the psychedelic drugs, is that I've described to you that they, you have this drug that it binds to a receptor, but actually the same, if we think about it as in terms of a lock and a key, where the drug is the key and the receptor is the lock, the key opens many, many locks. In the case of ketamine, there is a whole lot of different things that it's doing, a whole lot of locks that it's unlocking. And as well as that, when ketamine gets metabolized in the liver, it actually creates metabolites that float around in your blood and go into your brain, and those metabolites are active too. So although it binds to things like sigma receptors and NMDA receptors and HCN receptors and uptake transporters, we're really not sure how ketamine's pharmacology is going to create its dissociative effects and also its clinical effects. So this is kind of a bit of a mystery that we still need to unpack about how it works. And the same is true of the serotonergic psychedelics, where we think mostly these things are working through 2A, but again, we've got a situation where the key unlocks many locks. So the pharmacology is quite confusing. One sort of, and although they bind to many different receptors, one thing that seems to be emerging from the most recent literature on this is that a kind of common thing that seems to happen, regardless of whatever receptors and stuff that these drugs bind to, they seem to be causing the cells to actually do something. And this is called increasing brain plasticity. And so when we think about like the brain, we often think about that it's quite a static structure, that it's kind of, you see these pictures of it in anatomy textbooks, and you see these pictures of cells like I've shown you, and it all seems very two-dimensional. But actually, it's not only is it three-dimensional, it's four-dimensional. And the cells are changing throughout time. Now, there's not a huge amount of new brain cells generated, but actually the long arms of the brain cells, these things called the dendrites, those are continually changing. And these little things on the dendrites called spines, and that's where the synapses are. And the synapses and then the receptors inside them, the spines and the receptors are continually changing. So they're not static, and the brain is not a static anatomical structure. It's continually changing. And what's been found is that in animal models, if you give, I think this is some kind of nematode, and it's also been shown in rats, that if you give these drugs to these animals, what you can see is actually they sprout new dendrites. And by sprouting of these dendrites, this is thought to reflect increased brain plasticity, where if you have these sprouts, then the brain might be in a situation where it's able to encode new information better. So hopefully that makes some kind of sense. So that seems to be a kind of common thing that LSD, DOI, and DMT do it, and as we'll see in a little bit, ketamine also does that. So although they seem to be binding to all these different receptors and creating these quite unusual experiences, downstream they seem to be doing something relatively common, and that's promoting anatomical plasticity by increasing spine genesis, neurite growth. So, and although they are doing that, they do have different psychological effects. So you know someone, or a person obviously knows if they're taking, the experience of taking these psychedelics is different for all the drugs and at different doses, and the observer can observe these as well in patients. So, for example, ketamine has a very kind of disembodied experience that people have with out-of-body experiences, relatively blissful, quite complicated imagery compared to, for example, LSD, where people might have more spiritual experiences and certainly highly visual, with a lot of synesthetic blurring of audio and vision and elementary imagery, so visual kind of disturbances. So we can attempt as scientists, when we give these drugs, try to in some way try to quantify the different perceptual experiences that people have. And if we have those, then what in my work we'd be doing a lot of is trying to link those different perceptual experiences to what we can record in our brain scanners. But I'm not going to show you too much of that data tonight, because what I'm going to get into instead, having kind of told you a little bit about how these drugs work on the brain and how we're starting to uncover the way that they work in the brain, and some of the effects they have on the central nervous system, is, well, that's very nice, but maybe these drugs could also have some kind of therapeutic effect. And that's indeed what the scientists in the 1950s and 60s were looking at, was Could these drugs have therapeutic purposes? Now, the problem, of course, because of prohibition, from about 1970 till about 2010, there was basically no research was done on these substances. And then we're now getting to the point where we're actually able to do patient studies with some of these things. There was a long time where nothing happened, and then scientists were able to start giving them to healthy people. And now we're in a situation where we're actually able to give them to patients in clinical trials to test to see whether they do have some kind of clinical effects, which is so at this stage, the kind of field in terms of investigating the clinical effects of these drugs is still in its infancy, and that's been caused by prohibition. And that prohibition has made it very difficult for researchers over the decades to do this kind of research. But now kind of society in general is becoming a bit more open to actually considering this. It's enabled some scientists around the world to start looking at the efficacy in mental health conditions. So I'm going to show you some of the key results that have happened. And I guess the psychedelic which is the most advanced in terms of its clinical development is definitely the use of ketamine in depression. This is just a paper we did, but there are dozens of clinical trials now demonstrating the same result, which is that following a single dose of ketamine, that patients have this rapid antidepressant effect. So here we have on this graph on the left-hand side, we have what's called a MADRS score. This is essentially how depressed somebody is. So a MADRS score of 30, that's a pretty depressed patient. These patients are treatment resistant. Some of these patients, they had been unwell for 5-10 years longer and had been suffering for a very long time and treatment resistant, and many of the psychotherapies and drugs that they'd previously tried had not worked, at least 2 failures in our trial. And there's this kind of remarkable thing happens that after a single dose of ketamine, you get this massive remission effect. Our placebo was actually remifentanil, another anesthetic, to try to disguise the ketamine. And some people would say, well, maybe it's just because they, essentially got high, right? And maybe it's because they got high that they have this antidepressant effect. But the problem with that argument is that we know from the pharmacokinetics of ketamine, essentially ketamine goes into the blood and then it starts being cleared by the liver straight away. Its half-life is about 4 hours in the blood. What that means is basically a day after you've been given ketamine, you can give a blood or urine test and you won't be able to detect ketamine because it's very rapidly metabolized out of the body. So what that means, after about a day, there's no ketamine left in the body. But what you can see after a day is that there's still this rapid antidepressant effect. And people recover from an injection of ketamine after an hour or 2. So what's happened here isn't that the participant or patient is high. The high has gone long ago. The ketamine has left their body. What has happened, though, is something has changed in their body or brain. And we are thinking that it might be a change in their plasticity, because if you do the same experiment on a rat on the right-hand side, here's a control rat, here's a rat that's been stressed out in its cage, and then when that rat, and you can see that it's the spines of its frontal lobe become kind of dwindly compared to that one. And if you give that rat ketamine, you can see that it starts to restore some of the richness of the dendrites. So that might be the mechanism by which ketamine has this antidepressant effect in humans. And it's important to bear in mind that this is a really remarkable thing, because the effect of ketamine in patients with depression happens so quickly, whereas a normally prescribed antidepressant like Prozac or whatever, that might take 4 to 6 weeks to have an effect. Ketamine will work within a day. So that means that you can have much more rapid relief from symptoms. And it's now ketamine is actually approved for use in New Zealand. MedSafe approved a particular type of ketamine in January 2020, just prior to the pandemic, called Spravato. And Spravato is S-ketamine, which chemicals come in kind of two forms, where the guys basically mirror images of each other. And what Janssen did was they stripped out one side of it and took the S-ketamine, put it in a nasal spray, and then you have this something that they could essentially patent and sell, and then they ran clinical trials on it. So it's now a MedSafe approved medicine for depression. Unfortunately, it's very expensive, and it's not pharmac subsidized. And the other unfortunate thing is that in New Zealand, uptake of ketamine as a general use drug has been kind of painfully slow. Not many clinicians are prescribing it yet. Whereas maybe in the United States is a bit more the Wild West, and there's ketamine clinics that have popped up all over the United States now offering ketamine treatments to patients, and potentially not as regulated as it should be. So that's probably the most advanced psychedelic that we have in terms of being used clinically. Another one that you will have heard a lot about is potentially psilocybin. So psilocybin is the active ingredient in magic mushrooms. And the first paper from this came out in 2016 by my colleague Robin Carhart-Harris. And you can see these are patients, similarly depressed patients, and you can see that 1 week after giving a single dose of psilocybin, they have this massive antidepressant effect. And unlike the ketamine graph, which I showed you here, where people remit and they kind of, one dose works for like a week, maybe 2 weeks, with psilocybin, they were looking at 3 months of remission from symptoms from following a single dose, which is kind of remarkable. They followed that up more recently in a randomized control trial where what you're looking for here is reduction in symptoms across all these different scales, with psilocybin being the red, and they use citalopram as standard antidepressant as a placebo. And what you can see is that psilocybin was generally more effective than the standard antidepressant. But one of the things I kind of point out about this paper is that it's always coupled to psychotherapy. I'm being told to hurry up, so I'm going to hurry up. So another application of psychedelics is to psychotherapy, is to PTSD. And so MDMA-assisted psychotherapy has most recently been shown in a phase 3 study to be quite effective in PTSD. And the next trial for that is coming down the line, and we might expect in 2023 for MDMA-assisted psychotherapy to be approved for use. I'll skip over that one. Another way of thinking about psychedelics that we've been thinking about is this thing called microdosing. This is where people, instead of taking one big whacking dose of a psychedelic, they take lots of small doses, and this is called microdosing. So small doses that cause a slight perceptual change, but not enough to make people trip. And there's all this media attention about microdosing in the literature. But at the moment, there's virtually no science on it. So, and what we know is that there are tens of thousands of people microdosing around the world, and there's no scientific evidence on the topic. So currently at the moment, and I have seen some of my participants in the audience, that we're currently running a microdosing study at the University of Auckland on healthy volunteers to test the safety of this and to test its effect on mood and all that kind of stuff. Because what we're interested in is whether it can be safely used, and then whether it could be tested, microdosing therapy, as a potential antidepressant or as an adjunct to psychotherapy. And I think I'm almost done. If I can, 2 more minutes, guys. So what are the issues that are going to face psychedelics as we try to develop them as medicines? Well, some people say, well, can they be addictive? Actually, LSD, psilocybin, they're not very addictive. They have very low addiction potential, so that's good. They're relatively safe physical drugs, but you need to make sure that people are being screened for psychosis and cardiac risk. So these shouldn't, when we give them in a medical environment, they're pretty safe. So they have to be done under medical supervision with appropriate screening. And this is my last slide. And while data is looking pretty promising, there's a challenging path for these drugs to be fully integrated into our medical system. And one of the big problems that the field will face is that because these drugs are quite old, like LSD and psilocybin, they can no longer be patented under our normal medicines regime. So while there's a lot of interest from pharmaceutical startup companies, what they have to do is try to work out where they can find intellectual property to make money from it. So that's going to be interesting as we navigate the next 5 to 10 years of psychedelic medicine. And I'm going to close there. Do I stop my share now?
Kia ora, Suresh. That was very interesting talk, and I'm sure there's going to be lots of people who have lots of questions. So if you haven't written a question already, make sure you write it in the Q&A and or upvote the questions that you're interested in hearing. But we'll give you just a little moment to do that. And in the meantime, I've got a couple of questions for you, Suresh. So actually lots of questions, not quite sure where to start. Actually, maybe we'll just start at the beginning. You mentioned right up front about the kind of indigenous traditions, in many parts of the world of using psychedelics. And I think you also mentioned that here in Aotearoa we have some native psilocybin mushrooms. I'm wondering if you know if there is any kind of indigenous practice with Māori in Aotearoa. If you've got any idea about that?
Yeah, so the current knowledge, we've asked around about this, and the current knowledge is that there didn't seem to be, the current like tauhanga medical practices don't seem to have any knowledge of that. But we know because of the Tauhanga Suppression Act in like 1910 or whatever, that they probably frowned upon this. And so that knowledge might have got lost from there, because we know the Maori knew everything about their natural flora and fauna of Aotearoa, but for some reason they have this kind of black spot where they don't seem to have this traditional knowledge. So it seems to me very unusual that would be the case. So I suspect something has happened sociologically there that has limited that knowledge base.
Yeah, great. Thanks. And I guess that's something that, maybe we'll find out more about as things unfold over the next few years. And so you were talking a lot about the future of psychedelics, and I mean you're doing all this really interesting work, and in some ways that work is an extension of things that have been around for a while, and in other ways it's really new and nothing's been happening over the last few decades. I'm just wondering where you see things heading over the next kind of 5 to 10 years in terms of the research.
Yeah, so I think there's a lot of money going into the sector from new pharmaceutical startup companies. So I think we're going to see a lot of research happening that's industry funded from people that think that there's money to make here, and maybe there is, but that will create some of the investment that's required to actually push these through as medicines. And then I think we're going to start to see, so MDMA will be first off the block for PTSD. That's actually funded by MAPS, the foundation, as you know. And then some of the, probably psilocybin for depression, there's a company that's been working on that, and they're in phase 2 or 3 at the moment. So that might be only 3 or 4 years away. So I'd say within maybe 5 years, there'll be a few things as it moves from market into products. But then, of course, we're stuck here in little old New Zealand. Well, I assume most of us are in New Zealand. And what happens is that companies will start in the big markets, and they start moving products into the big markets, and it'll take a while before they come to like little old New Zealand to market product potentially. So we might be a few years away before, unless we get ourselves on the radar somehow, we might be kind of, hopefully not at the back of the queue.
So have you got any ideas around how we get ourselves on the radar?
We get involved in the research so that we have all the so that we have all the infrastructure in place to do it. So, and that's physical infrastructure in terms of like the clinics that you need to kind of do this kind of work, but the human infrastructure, the expertise of therapists to be able to actually, because it's not just, these things aren't just a drug that's given and the person's left to, trip and then go home. It's been working with therapists, and so then you have to have like a good pool of trained therapists. So there's physical infrastructure of the healthcare, and then there's actually the expertise to actually deliver the things. So doing the research and building up that infrastructure, both human and physical, will get us closer and further up the queue.
Great. Okay, let's move to some questions that have come in, because I can see we've got plenty. Let's start with this first one. Not sure who this is from, but it says, when comparing traditional antidepressants such as SSRIs, what's the benefit of psychedelics over those sort of traditional antidepressants?
Yep, so if they're shown to work, which is still an open question because the trials haven't been finished, but if they were shown to work, one potential advantage is that the model of a pharmacotherapy is very different to normal antidepressants, because in normal antidepressants you basically start this antidepressant course and then you're taking that pill for a long time, potentially years, whereas with the and then you've got years potentially of side effects that you're having to deal with, and tolerance issues and withdrawal issues, and like all these side effects that users really don't like, whereas the psychedelic intervention is maybe just 1 or 2 doses, maybe every 6 months or a year or whatever is needed. So that means the side effects, and that it's a much more concentrated therapy regimen. So potentially a benefit might be that you don't have this extended kind of side effect profile that patients are having to deal with for a long time. And then it may just be that some people standard therapies work better for, and some the psychedelic therapies work better for. So it's potentially it's about offering different alternatives for patients.
Yeah, great. A lot of people have upvoted the question, how can I join your microdosing study?
Wow. We're at full recruitment at the moment. Sorry, guys.
Good to ask. Okay, so do you know whether MedSafe or Pharmac are looking at making ketamine available in New Zealand for depression?
Yeah, so as I mentioned, Spravato is approved by MedSafe, so it can be used by clinicians, but it's very expensive, which requires Pharmac to subsidize it. And I think maybe Janssen applied to Pharmac and Pharmac said no, or you need more evidence, or something like that. So it hasn't got Pharmac subsidy yet. Now, on the other hand, the racemic ketamine like we use is Pharmac subsidized. It's really cheap. It's only $20 a vial. It costs almost nothing. But the problem with that is that version of ketamine is approved for anesthesia and not for depression. So if a medical doctor wants to give that for depression, they have to do what's called off-label prescribing, and many doctors will be reluctant to do that, especially for a controlled substance. So we're kind of caught in this like dual place at the moment.
Okay, thanks. Okay, so with the rise of cannabis in New Zealand, we've seen the difficulty of introducing it into culture as it is a Class C drug. Actually, there's a few questions on this one. Firstly, why do you think it has been so difficult to introduce it? I'm assuming that's about cannabis. And secondly, it would be much harder to introduce LSD into society for medicinal purposes, considering it's a Class A drug. How would you go about doing this?
Well, so I mean, we try to separate the recreational or the lifestyle use from the medical use. Now, I know that there's kind of like a pretty grey divide sometimes between that, because some people are using substances sort of recreationally and medicinally. But I think the way that the psychedelic research field is going is not really around kind of the more lifestyle, personal improvement, or just having a blast type usage. I think the psychedelic research with things like LSD and psilocybin are taking a much more kind of medically focused approach. And so, like for cannabis, actually, right, like there's already probably as many clinical trials with the psychedelics as there are with cannabis, even so. Like, and there seems to be a much greater appetite for running clinical trials with the psychedelics than there is with cannabis. So I think that, or cannabinoid type drugs. So I think that psychedelics are going in a very kind of clinical trials framework, whereas cannabis is kind of caught in this, like, half the industry wants to kind of like medicalize it and half wants it to be recreational, and it's kind of all a bit blurred up. So, but it is a tricky kind of ground between the two.
Okay, thanks, Suresh. Okay, so someone else has asked the question. I have antidepressants prescribed for chronic pain. Is a psychedelic a potential alternative?
I'm not going to provide specific medical advice, but what I would say is that there is some investigations looking at psychedelics for pain syndromes and headache, but the data is still very early on. So
yeah, okay, fair enough. Okay, someone else has asked, can you talk a bit more about the high dose experiences, particularly ego death experience, and how does science deal with the spiritual aspects of those?
Yeah, so it's certainly true at the very high doses of particularly something like DMT, that you get these kind of, not an ego death, but or what feels like near-death experiences. And in terms of like running clinical trials or studies with that, requires a lot of preparation work with therapists and post work with therapists, and a lot of, so someone's not just going to turn up to the clinic and you're going to kind of give them a dose that's large. It's going to require a lot of kind of careful discussion with the participant or patient to kind of manage that, what can be very profound experiences or very powerful experiences, at least. So that has there's a lot of management involved. And like when I talk about these studies, right, we spend a huge amount of time managing participants and patients and their safety and all this kind of stuff. So they're not interventions that are done lightly.
Okay, a question here. While magic mushrooms may be low risk, are they perhaps classed as class A due to potential mix-ups with deadly wild lookalikes?
So,
you know what?
Yeah, I'm not 100%
Don't
sure. Yeah, I have to admit my mycology isn't very good. There's probably people better to comment on that. But yeah, I don't think they're classified based on mix-ups, or that, you know, that people might pick mushrooms and pick a toxic mushroom and eat it. That's why they're classified as high risk. I think that's kind of just a peculiar side effect.
How much is known about potential interactions with other pharmaceutical medications?
That's a really good question. So for ketamine, one of the really handy things about ketamine, and particularly as an antidepressant, is that you don't need to stop taking a standard antidepressant for a medical doctor to prescribe and give ketamine, administer ketamine, and it's going to still have the same antidepressant effect, basically. So that's really simple from the ketamine side of things. Now, for the serotonergic side effects, we don't really know, but people generally, recreational users tend to say that that taking something like a SSRI or something is going to interact with LSD, and so people don't recommend taking them both together. And we don't really know from a clinical trials perspective, because that's just not done. So people are always not on standard antidepressants, and I don't think there have been any studies where they've been looked at the same time. So, because we're kind of boring, so we try to study one drug at a time. So we try to avoid that interaction, but probably it's not a good interaction is what we're thinking, but there's not that much evidence on it.
Mm. So sounds like more needs to be done in that area.
Yeah, for sure. Yeah. Great question.
Now, someone's asked a question about your last slide where you had something about health economics on it, and they just wondered if you could talk a little bit more about that.
Yeah, so yes, so like for this is something I wonder and worry about, is because if you've got so one of the models, for example, like the psilocybin for depression model, there's actually a huge amount of psychotherapy is done in that Carhart-Harris paper I showed you. There was actually about 40 hours of psychotherapy went along with the psilocybin intervention. Now, if you try and work, we struggle to get 4 hours of therapy for 4 hours of counseling for a patient who's got depression in the New Zealand healthcare system, right? So if you add up 40 hours of therapy time plus the medical intervention and all that kind of stuff, how much is that intervention actually costing the healthcare system, right? And does the health economics of that make sense? And then if the health economics doesn't make sense, is that just going to become a therapy for the rich, right? And only rich people are going to afford that. And is that just going to create more inequity in our society where the rich can have this therapy, but the poor can't access it? So that's a real concern. And then can you strip the therapy? How much can you strip the therapy back to make it more affordable? So these are like really important questions if they to become more mainstream medicines.
Great, thanks. Someone else has asked a question about something that you mentioned in your talk about the political convenience driving the classifications of these substances. Could you talk a little bit more about the political convenience?
Yeah, I mean, it's certainly true that it is political convenience that drive it was politics that drove the original classifications in the 1970s, and now it's just like no one wants to even look at it because so now it would require reclassification, and reclassification would require some kind of political will, but certainly in New Zealand, there's no appetite for looking at reclassification. There's no appetite from politicians to do anything around evidence-based classifications, because I won't get into the specifics of the politics in New Zealand, but one can imagine that certain parties don't want to raise these things as issues because they don't want it to become political football and they don't want to lose votes, and so everyone just throws it in the too hard basket. So it's just kind of, it's just... Yeah, as I like to say, like, we like to listen to epidemiologists when it comes to things like COVID-19 and immunologists when it comes to vaccines, but we don't want to listen to psychopharmacologists when it comes to drugs. So yeah, our politicians' use of evidence is selective.
Okay. Now, a question here from Joel. He says that some scientists are saying that psychedelic drugs have the potential to increase the human connection with nature and thereby be useful for climate change awareness and action. Have you encountered this in the literature yourself, and do you think it has any merit in this line of inquiry?
Yeah, so there's been one study that I'm aware of where they actually looked at something called the Nature Relatedness Questionnaire. I think this came out of London as well, and what they showed was that they did, I think, the questionnaire before and after the psychedelic, and they showed that people did increase their kind of connection, did have a kind of long-standing increase in their connection with nature. So there does, and this comes through in the anecdotal reporting, of course, as well. So there might be something there, and so maybe it could. I don't know. I suspect that the biggest impact would be as if some billionaire took it and then decided to donate their fortune to actually doing something useful with their money. That would probably be the largest effect on climate change that psychedelics might have, rather than the mass of the population.
Right. That's an interesting thought.
It's fun as fun to spaces for them, they do something useful.
Yeah. Okay. What else have we got here? Joel asks another question. He says, with 1 in 5 Kiwis experiencing challenges with mental wellness, do you see psychedelics playing a significant role in the future of mental health measures?
It's difficult to say. I think that they can certainly be a treatment option. They're most likely to be for the more severe anxiety, depression, internalizing disorders. So they're not going to be a first-line therapy. In terms of that bulk of, the biggest tools that we have to correct mental health aren't in treatments, but they're in prevention. And the biggest tools for decreasing prevalence of mental health disorders is providing food security, health, housing, all these basic social infrastructure. And that's where we're going to get the biggest gains in terms of the epidemiology of our mental health pandemic. But when we come to those very severe cases, I think that's maybe where we've got another option, and that where psychedelics can provide an option for the treatment. Maybe not the 1 in 5, maybe the more like the 1 in 50 to 100 is probably the ones that are going to benefit from this kind of therapy.
Okay, thanks. To your knowledge, have samples been inclusive of people across genders and ethnicities? Any indications of distinctions across demographics?
It's across genders is pretty good generally. Across ethnicities has been okay. The biggest problem, demographic bias in the literature, I would say, is that it tends to be more highly educated people. I think that's the common bias in the studies that have been done so far is actually around probably education level. So that's something to correct. And the studies have largely been relatively small sample sizes. So as the sample sizes get bigger, because we're only in the sort of the small phase 2 trials, so as we get into the bigger phase 3 trials, we do need to make sure we have better representative sampling. So it's not too late to correct this, but it's something that needs active thinking about. So it's a great question.
Great, very good. And I think I've just looked at time, and I think we're just about out of time. So I really want to thank you, Suresh. That's been a fascinating talk, and some really interesting questions. So thank you everyone for the questions that you've posted. It was interesting questions, and really great to hear your response to those questions, Suresh. I'm sure everyone like me has enjoyed hearing what you've had to say. Raising the Bar, the home edition, is a series of 6 speakers over 6 weeks, and today's speaker was the 5th of the series, and we have 1 more remaining. We hope you'll be able to join us again at one of the other talks, or at our final talk. To do this, please check the link in your confirmation email that you received to join us today. We'll also show the website address at the end. Thank you for joining us today, and we hope to see you again soon. Ka kite anō.